Well, hello, everyone. I'm Beth Johnston. I'm the Chief of Community Engagement here at the FSHD Society. And together here with my colleague is June Kinoshita, our Director of Research and Patient Education. We'd like to welcome you to today's FSHD University. You may have heard about a little something called Project Mercury. But what many of you don't know, that even if a drug therapy makes it through the FDA process and is on the market, patients may not be able to afford it. Insurers, government payers often delay or even deny access because they don't perceive the value of it versus the cost of it. So Project Mercury is a global initiative that was created just to tackle this issue. And patients and the community must play an active role in advocating for therapy access. So today, to speak to us about Project Mercury, we welcome Josie Godfrey of Project Hercules, who has worked on exactly this issue in other rare diseases and is now a consultant to Project Mercury. And we also have our very own Ms. Amanda Hill, Director of Clinical Research here at the FSHD Society. So without further ado, to tell us more, we welcome first Josie Godfrey and then Amanda Hill.
I'm just going to attempt to share my slides. Hi, everyone. Let's see if this works. I have a terrible track record of sharing slides, so hopefully you can see them.
Thumbs up.
And even there we go. Is that working?
It's working. It
Brilliant.
is working.
So I'll just take a moment to just introduce myself, because you're probably wondering why this strange woman with a British accent is talking to lots of Americans living with FSHD. There is a reason, and hopefully it's a good one. So I have been working in rare diseases for about 15 years, which makes me feel terribly old, but it also means that I've had the opportunity to work across dozens and dozens of rare diseases with hundreds of patient organizations over the years. And a lot of that work has been on something that we call patient access, which is about trying to actually get treatments that have been developed to patients and get companies reimbursed for that. And so I'm going to talk to you today a little bit about what I mean by patient access, why it's important, touch a little on some of the differences there are in different countries. So I'll try and bring it back to the US as we go, but I'm going to talk about it at quite an international level in terms of the things that are common across all countries, because Project Mercury is actually a global initiative. And then I'm going to talk specifically about the access work on Project Mercury, and then I'm going to hand over to Amanda, who will talk about some of the activities that are already happening and have been happening in the US, very sort of important activities. So hopefully that's going to cover what you expect it to cover, you're hoping to learn today. Please do put things in the Q&A. I am very relaxed about being interrupted. So if I say something that makes no sense to you at all, please put something in and ask me to explain as I go, because it will help your understanding with my presentation and with you really getting what you need from this webinar. Okay. So just to start with, what do I mean by patient access, and what does Project Mercury, and I think these days the FSHD Society, mean by patient access? So you might be aware there's quite a lot of steps in developing new pharmaceutical treatments or new treatments of any kind. And at some point, there's something called licensing or marketing authorization. So that's when in the US, the FDA would do their job. They'd say, yes, we approve this for use in America. And that's great. It's great. Really important part of the process. But what they're asking is, does the drug work? Can it be developed to a consistent quality? And is it doing, more good than harm? Is it relatively safe? What they're not asking is, sort of how good it is and how does it fit and does it meet the needs of the patient population? Those questions come later, and those processes are part of patient access when payers, so whether that's insurers, Medicaid, Medicare, in different countries, there are very different systems, but they're all interested in, is this worth it for our patient population, for our health system? And even when they've decided, then you're looking at adoption, diffusion, are clinicians actually prescribing these treatments? Do patients and families actually want to make use of these treatments? So there's a lot going on in that set things that happen in the life cycle, if you like, of a product, of a new treatment, after the FDA or any other regulator has said, yes, it's okay to use this in this country. So in terms of the patient access landscape, there's something called health technology assessment. I'm not expecting many of you to have heard of this. Some of you may have done. It is a relatively niche thing in the US at the moment, but it's rising in influence, and we'll talk a little bit about that. But it's very, very common in many, many other countries. So it's quite a core part of the global access issue, and we'll go into what's involved in that in a couple of slides. We've got national payers, so it might be Medicaid, Medicare. In a lot of countries, there are national level health systems. I live in the UK. We have a single national health system for the whole country, and that is a national payer. There are also regional or local payers, so you might have state level or even small insurer companies, for example. And then you move on to the sort of what we'd call prescribers. There's prescribing healthcare professionals who are actually going to sort of give you the script for the new treatments. And within that, it's all about the patient access. And they're all interested in similar but slightly different things, and there's slightly different ways of engaging with them that we'll touch on. You might say, well, that's great, that's very interesting, but what is this access issue anyway? That Beth said, why on earth would people not be getting the treatment once it's been approved? What's the point of that entire process? And really, it's about individual health systems, individual countries or payers saying, there's a lot of new products coming through. Is this one that's going to help our population, the people that we're looking after? And is it going to be worth the amount of money that the pharmaceutical company wants to charge for it? And there's different variations on it, but sometimes that can be really difficult because it can ask different questions, ask different evidence, and we'll look at that, and it can take a lot of time. So this is a little bit of an old slide, but the principles stay true, that shows how long it can take after that approval from a regulator. So after, say, the FDA said yes, it's looking here, it's taking on average about 252 days for it to be properly launched, properly reimbursed within the US. And you can see that that's pretty quick compared to some other countries globally. So in Mercury, we're working with a lot of different countries on the same issues that will help all the countries involved, hopefully speed that decision up, make it a simpler decision, a more productive decision, but also a quicker decision. I'm just going to, so there's lots of different factors that can help drive successful access to a new treatment. So the clinical benefit, obviously, of a new product. So how effective is it? The impact on the health system. So does it slot in to existing pathways of care pathways, the existing clinical interventions that you already have? Or is it actually requiring a very new kind of pathway, new training for healthcare professionals, new resources within a hospital system, for example? It's also really important around the alignment with political priorities, and Amanda will touch on some of the activities she's been doing as we get towards the end of this session. But that clinician pull, so do clinicians believe in this product? Do they think it's meeting an unmet need? But also the patient pull, the pull of the community, the patients, the families, the people actually living and affected by a condition. I have seen treatments that the patients go, this is not for me. Perhaps the side effects are really just overwhelming, and it just is not worth what is perceived to be a small benefit. In other times, I've seen situations where clinicians have maybe not really understood just how important a new treatment was to patients, because again, perhaps it's got far fewer side effects than the treatment that clinicians may think is doing its job, but actually can be really damaging and challenging for patients. So there's a lot of reasons why you as individuals and you as a community will really have a role to play, just in terms of like, do we want this? And how are we talking to and engaging with clinicians about this? It actually also matters what other treatments are out there. Now in FSHD, we know that we're going to be looking at potentially the first properly licensed treatments for FSHD coming through. But one thing that payers may have in their heads is what else is in the pipeline, what else is coming. So they're always trying to understand that wider landscape. And what we're going to get into now is the importance of the evidence and the uncertainties. So everyone in this system, all of the different organizations are trying to manage the risk to them, to what their function is, manage the risk and minimize that risk when they're making decisions about new treatments. And they minimize that risk by asking for really robust evidence about the condition and about the new treatment. We're going to sort of walk you through that a little bit now. So, excuse me. So regardless of the system, or regardless of the country, these are the kinds of questions that the decision makers are going to make. So for you, that might be Medicaid, Medicare, a local health insurer, an employer health insurer, whatever it is, whoever that person, that organization is, these are the kinds of questions they're going to be asking. And in the little grey boxes is the kind of evidence they're going to look at in order to answer these questions. Do we need the intervention? What's the burden of illness, the burden of disease? Can we actually identify the patients who would benefit from this treatment? What's our diagnosis route like? Are we good at detecting these patients? Can we find the people that would benefit? Is it safe? What's the efficacy, the safety profile? How well does it work? How meaningful is it? So is it really impacting on quality of life as well as just sort of clinical markers? And then this big question of, is it worth it? Which here in a lot of countries is around cost effectiveness. The US has been quite different, but there's an organization called ICER. You may or may not have heard of it. We can certainly talk a little bit about it, but that does take a cost effectiveness approach. And that's really sort of weighing up if the amount of money that a new treatment might add to the health system is seen as offering good value when you weigh up all of the benefits of that new treatment. They're also probably asking, can we control its use? So some new treatments might start with a very targeted, focused population. You have something that's called scope creep. And actually then clinicians start prescribing it for an awful lot more patients. And suddenly the bill is, 20 times what was anticipated. And the benefits in those additional patients might not be as great. So I'm really trying to understand, what would the use of it look like in the real world? Who would it really be given to, and what benefits would we really see? And then at the end of the day, there's sort of a, can we afford it? Some of you may have seen newspaper articles or, online discussions and things popping up on the news that say, world's most expensive drug is approved or rejected for use. This happens almost every 6 months. There's a new world's most expensive drug. And I've been involved in quite a lot of them over the years in different rare diseases. And it is a genuine anxiety for a lot of health systems to be able to say, can we afford this in the light of everything else that we've got to have coming in? Is it worth it for these patients? Can we justify the expense? Or can we justify not making that, given all the benefits that it might bring? So all of these different pieces of evidence, a lot of them come together about the disease. They're not all about the treatment, the individual treatment. So whilst the companies, when they're developing their new products, will develop really, we would hope, really strong evidence about how effective that product is, has to be understood against a backdrop of, what do we know about the condition? What do we know, in this case, about FSHD? Do we understand what's currently happening with people affected by FSHD? Do we understand the disease progression of FSHD so that we'd be able to identify those patients that might most benefit from a treatment? Do we understand what would happen to people living with FSHD without that treatment? And so we're always looking at, what is the comparison, if you like? What are things like now, and what would be different with this new treatment? There's a lot of different evidence. Some of it gets horribly technical and way above my head. And some of it's really quite straightforward. There's a big mix, but all of that needs to be supported by evidence, because if you remember, these organizations, these decision makers are trying really hard to reduce the risk of making the wrong decision, of saying yes to something that turns out to not be that great, or saying no to something that turns out to be revolutionary. So they're always trying to kind of balance those risks. And the more evidence, the better they feel about making decisions, the more likely they are to be able to move quickly and confidently towards a positive decision. So it's a number of things, all of which, as they say, are at a disease level. And that's really where the global part of Project Mercury is being focused at the moment. It's on building that disease level evidence base. So there are a number of different work streams around Mercury. I don't know if you had separate webinars on those yet or you're going to, but the work that I've been asked to support is the patient access work stream. And here we're looking at trying to remove some of these well-known barriers. So that's the kind of evidence issues, for example, to really bringing access to therapies as quickly as possible from the date they're approved by regulators. And there are challenges. We talked about that sort of availability of the robust clinical data, the readiness of healthcare professionals to work together. We need that disease model, that disease progression model for people to be able to understand what is different with the drug compared to without the drug. How much have things improved with this new treatment compared to without the treatment? There's also something called health-related quality of life, or quality of life with big capital letters. And that is not necessarily how we might talk in our day-to-day life about our quality of life and how we're feeling. It's an attempt to capture that, distill that into something a little bit more quantitative. So it's actually quite a formal, structured way of trying to measure that in a way that can be compared between different conditions, between different people. It's not ideal. There's a lot of challenges with that approach. But one of the things that will be really important, a little bit in the US through this organization called ISA, but a lot in all of the other countries that are part of Mercury, health-related quality of life becomes almost the unit of measurement for how effective a treatment is. And so we will be looking very much at how that can be best used and how best measured within FSHD. So our priorities I'll put them all up, for the next period, so 2024 and 2025. Quite a lot of priorities, which is going to be very busy, June. We have to create and publish this disease model, and we have a plan in place to do that, so to access all the clinical data that we're able to and start to build this disease progression model so we can understand what is happening now and have the evidence to support that understanding. And that evidence will come from registries from clinical data that we're allowed and it's appropriate for us to access anonymously, of course, but also from engagement with people like yourselves with lived experience to say, let's bring some together in a focus group, in a conversation and say, does this data reflect your real world, real life experience of this condition? Or is it missing something? What is most important to you? So if I may, I'd use the example from working Project Hercules, which has already been referenced. This is a very similar project in Duchenne muscular dystrophy. Now, Duchenne muscular dystrophy is a truly devastating condition. It's not as varied in its progression as FSHD. But what we found was actually we thought we were going to find what we already knew when we started the work building a disease progression model. We thought we would move from early to late ambulatory stages through to early and late non-ambulatory stages. And all we'd be doing would be bringing the evidence together to support a very widely used and accepted disease model. What we actually found, because we went beyond the data in front of us to bring in clinicians, bring in healthcare professionals, bring in, even more importantly, people living with the condition and people with family members affected by the condition, and ask them, does this reflect your experience? What were the most important parts of your journey with your condition? We actually introduced a disease stage that hadn't really been described or defined in the literature. And this was between the ambulatory and non-ambulatory stages. So when the boys, and it is mostly boys, were able to weight bear, to stand, to participate in transfers from perhaps wheelchair to car to bed, for example, but not really able to walk, not able to be considered a walking person, but able to support their weight, the transfers. And this was so important to the boys, so important to families, and it also impacted on the kind of clinical care and the quality of life with those big capital letters that I mentioned before. With FSHD, I think we're going in with a much more open mind as to what we might find from the data and that what is going to be most important. And we really will be looking to hear from people who have been affected by the disease. We will be looking at this health-related quality of life measure, the measures that have been used in trials, the evidence that is out there around what fits well in terms of capturing what's important to people living with FSHD. We'll be publishing some work that's already happened in the US and in the UK, which has been looking at cost of illness. So we'll be making sure that we put that out in the public arena, and we build on that with looking at the other countries involved in Mercury. Be building a toolkit for patient organisations, so including the US, but beyond that as well. So I was saying, okay, well, are you ready? What do you need to know to be able to participate in patient access processes in your country? And where are you now? So can you check where you're at? Where are your gaps? And you can get prepared and get ready, because we know, and I certainly know from my work with, as I say, probably hundreds of patient organisations now, that preparing early and having a plan makes such a difference to the success of patient involvement in access. So it's fantastic the FSHD Society is getting involved now. We'll also be making sure that all of this work is shared pretty broadly with stakeholders who are part of this decision. So there's health technology assessment bodies, those decision makers around the clinical and cost effectiveness of a treatment, the payers, academics, industry, because we find that if they're exposed to the kind of work that's happening, they more readily accept it when it comes to an actual decision about an actual treatment. So it's a really important part of the program. And in fact, just today, I'm in Brussels at the moment. I've been presenting some of the work of Project Mercury, just starting to raise awareness of the approach that we're taking. I think that, yep, so what are we hoping the impact will be of Mercury? I'm conscious I'm throwing a lot at you, and I can see there's already something in the Q&A. So Beth, June, just tell me if I need to go back and explain anything, please. So in those health technology assessment markets, so that's not quite the rest of the world outside of the US, but a big, big part of it. Certainly most of Europe, Canada, Australia, large chunks of Asia, and a little bit of South America are HTA markets, so health technology assessment markets, which means they have that part that decisions are made through the lens of the clinical and cost effectiveness to a large extent. So the disease model will directly inform those decisions. It'll be fundamental to the production of the sort of value story, the way in which companies are able to explain and demonstrate the impact and the value of the new treatments. The health-related quality of life, please forgive the use of acronyms, the measures will again directly inform those processes. The cost of illness toolkit, they will all be absolutely used quite a lot, and I'm seeing that happening in Duchenne and in other conditions. US specific, there will be some of that direct impact, particularly if ICER, which is an organisation, it's a non-statutory organisation that does undertake health technology assessment. It's heavily based on NICE in the UK, that's the name of the Health Technology Assessment Agency in the UK, which I used to work at. I set up their rare disease programme there. So I'm pretty familiar with what's happening in the UK, but also because the US organisation, ICER, has copied a lot of that, lent on it. They sort of worked at NICE for a while, the lead there. I'm very familiar with the approach that they take. So there'll be direct relevance and benefits from this work. But even outside of the role of ICER, the payers, the insurers, etc., increasingly are looking at, do we understand from this disease progression model, can we see what would be different with this treatment? Are we able to see if there's any costs that we're displacing or postponing if we get this new treatment? So there'll certainly be a lot of aspects that will be directly relevant to any payer, regardless of whether they're a health technology assessment market. We want to evaluate the success and the impact that we're having with this work. So have we managed to publish? We want to publish this model. We want it to be widely accepted. We will be working with the FSHD community and with clinicians, healthcare professionals, and academics, etc., to make sure that there's a broad consensus. If there isn't, if it's controversial, it's going to be really difficult to build on that and to have that as the basis for demonstrating the impact, the value, the efficacy and effectiveness of a new treatment. want to get these publications out, and the US team are working hard on the US publication, and we're working hard on the UK one as well. We may, and this is somewhat subject to the wider group, commission a disease level economic model. Now, that is quite specific to the health technology assessment world, relevant for ISA, but not for other decision makers in the US quite so much. And that's yet to be determined. So that would probably make a decision on that at the start of next year, maybe slightly later on. And then publish this independent review of the health-related quality of life measures that will allow that to inform the decision making and the value. And with that, I'm going to hand over to Amanda to talk a little bit about what's already happening in the country working group in the US. So within Mercury, there are 10 different country working groups. As I say, it's very much a global project. We have a lot of Europe, we have Canada, US, Brazil, Australia, and the country working groups are working at different paces in different ways. And the US has hit the ground running, and Amanda's going to touch on what she's been up to. Amanda.
Great. Thank you, Josie. That was a wonderful presentation, Josie. I think Josie does a wonderful job of explaining this world of access. And we're so thrilled to have her on part of our team, consulting with Project Mercury and really providing her insights and expertise and experience here. So as Josie mentioned, the United States, the FSHD Society is leading some of this access work here in the US, but we're just one of many countries involved in Project Mercury and many more countries that we hope to be able to cascade this work into in the coming years. So really this initiative has a very global focus. But here on the US side of things, I just wanted to share some updates on what we've been working on over the last year and a half or so, and where we're going through the rest of this year and into 2025. So really exciting update to share. You maybe have seen on social media just last week, we had our inaugural Hill Day event on Capitol Hill. So this was really kind of a seed planting exercise, very strategic in nature. I think we had, what was the final number? Somewhere between 12 and maybe closer to 16 patients, along with some of their caregivers. We all came to DC and we met with, I think, about 16 different congressmen and women. It was a mix of House and Senate representatives. And our goal for this day was really to start to build relationships with a bipartisan coalition of officials who can support and guide our future advocacy efforts, especially aimed at the payer systems in the US. And so this was an amazing, successful day. Really what these meetings were, we had they were short meetings. It was usually with some of the young staffers for the representatives, although in some cases, the groups got to meet, the different patient groups that you see here got to meet with the representatives themselves, which was very cool. And the time that we had with them, we really focused on just sharing our story, sharing a day in the life of FSHD, what some of the struggles and the battles are, and starting to highlight for them, look, one, we need awareness. We need more awareness about what FSHD is. We're not multiple sclerosis. We're not Duchenne. Like, we are our own separate disease. We have a unique set of needs. And we wanted to start to create that awareness there, start to create, to share those stories, and start to find ways that we can align with these representatives for advocacy efforts moving forward. So in our conversations, we were able to start to talk about and reference some ongoing, upcoming legislation that we knew some of these representatives would be looking at that would benefit, the rare disease community broadly. And then we were also able to specifically we asked each of them if they would consider sponsoring a resolution that would officially recognize June 20th, World FSHD Day here in the US. It's a pretty easy ask to get on board with, but it's just a nice thing to have a real action and a real goal that is something that these representatives can get behind, and something to start creating that, help us start creating that awareness. So this was, I mentioned, is kind of a strategic seed sowing exercise, because we know in the coming years, we will be leveraging these relationships and these networks to help ensure that we have the coverage that we need for upcoming therapies for FSHD. And in the future, we'll be doing more of these Hill Days to continue those relationships, and we'll focus those on whatever the urgent emerging issues are in the community at that time. Josie, you can go to the next slide, please. So on that note, what we're looking ahead to now for 2025 in our government advocacy efforts, we will be training and deploying patient advocates, all of you, to start working at the state level, especially when it comes to some of these payer and reimbursement issues. So as we get close to a therapy approval, we need to start learning how to engage with, there's these drug review boards that make decisions about Medicare, Medicaid in particular. So we want to start learning these systems and preparing our community, preparing you guys to go before them in your local areas and advocate for the appropriate coverage that you need to access treatments. As I mentioned, we will be planning upcoming Hill Days, potentially next year around June 20th again. And then we are going to be starting to engage with ICER. So Josie has mentioned ICER. This is an organization that tries to figure out, what would be a fair price for a drug, given the clinical evidence, given patients' perspectives about, how it improves their lives and how it affects outcomes. And so ICER does have a mechanism to engage with the patient community and for them to hear patient priorities. So we're going to make sure that we put the community in front of ICER and we start that conversation with them as well. All right, next slide, please. One before that. Okay, great. So other work that we are doing to sort of prepare the payer system in the US, and by the way, when I refer to payers, there's two camps in the US. So there is kind of a bit of a national payer system that would be Medicare, Medicaid, which is broadly referred to, you'll hear it called CMS as well. And then of course there are the private insurers, and we will be really looking to engage with a lot of those major insurers. You think like United, Aetna, Cigna, those sort of big names. Those are the types of payers that we're talking about when we use that term. So we are well on our way putting together two different studies looking at the burden of illness, or what you might hear called the cost of illness. And the purpose of these studies, and Josie had alluded to them, is to understand from a cost perspective, from a socio and economic perspective, how does FSHD impact our health system, and how does that impact productivity in a broader sense across the country? So we have two studies that are designed to address this, that we know that we need to do more, we need to generate more evidence. But where we're starting is we have an analysis of insurance and Medicare claims. So these claims data it's information about how much money your insurer paid on your behalf for XYZ, for a medication, for some sort of a doctor's visit, maybe for some sort of medical equipment that you needed. So it's not what you paid personally, but how much they covered on kind of the back end of things. So this work is nearly complete. We're finishing the publication on this now. And I have a little screenshot here, example of one of the tables. And I apologize, it's kind of an overwhelming format, but I just, as an example to illustrate the kind of data that we're producing here, I've put a red box around two comparisons. So this is looking at within any 6-month time frame. So this isn't even a whole year. This is within a half of a year. How much money does a commercial insurance company on average pay for procedures, services, and medical equipment for a person with FSHD compared to a control population, so just any random other person picked out of the general population? And there's two scenarios here. If you look at the bottom one first, you see 11,403 versus 3,622. So that 11,000 number is $11,000 that the insurer has paid for one, on average, for one FSHD patient within a 6-month time frame. So if you double that, little 22,000, closer to 23,000 within a year time frame, versus some other random person just picked out of the general population is like a third of that amount. So this is really good evidence for us to show to the payers and say, look, this is how expensive it is for someone, this is how much money you're paying for someone with FSHD, and this is how much money, the next phase of this would then be when there's a drug on the market, you can start to look out and say, this is how much you might save, in this scenario, if a person had an effective treatment and they were not progressing and didn't have all these additional medical needs. So that's the sort of evidence that we're looking to create, and we're going to be presenting where we can to these payers. The other study that is ongoing is outside of then the payer system, the patient community. We're looking to understand the out-of-pocket costs that the patient community has directly borne. So for things like vehicle modifications or home modifications or wheelchairs that your insurance does not cover, we can assign dollar values to that. And we've also are looking at kind of a little bit more like indirect socioeconomic impacts. So maybe you had to retire early. Maybe you have to take unpaid days off of work because of FSHD. Maybe you've lost some other sort of job opportunity or education opportunity that you just couldn't do, you couldn't pursue because of this disease. Those are all things that we're looking to understand. If you have been in the community for a while, you probably saw the true cost of FSHD survey that we did about 1.5 years ago now. That is where we got a lot of that data from, and we're almost done analyzing that. So we'll be publishing that hopefully later this year as well. And then, oops, go back one. Thank you. Publications coming soon. Yep. And I mentioned this as well. We know that this is just the beginning of our work of evidence generation. And so we are starting to look at additional studies that we will be pursuing in 2025 and beyond. Wonderful. Okay. And then the last thing I just wanted to mention briefly is a little bit indirect, but I think it's still important to mention is that June has been working really hard to coordinate a group, and we have a wonderful group of experts that have drafted an updated care guideline. And this will be published later this year. It is the full guideline is complete. It's just a matter now of getting it through into the journal and disseminating it to the doctors. And importantly, something we're going to be doing with these care guidelines is working with CMS and with some of those major payers to make sure they adopt these updated guidelines when they're making decisions about treatment and reimbursement. Now there's not a drug on the market now, so these care guidelines don't contemplate any drugs at this stage, but I think this will be really important for us to establish those relationships and start helping payers understand FSHD and understand the costs that are associated with FSHD, so that when there is a drug and we do update those guidelines, to say, okay, now the recommendation is to prescribe this drug to this group of people. There's already a baseline of understanding there and what those costs are associated with it. So those are kind of the major things happening in the US right now. We're really pushing forward on all of these fronts to advance these efforts with ICER, with the payer systems in the US. And yeah, excited to, we're going to continue to need the patient community involved in all of these efforts, as Josie has mentioned, that understanding kind of what the patients actually think and feel about the disease model, about their experiences on the drug, how it actually impacts your quality of life. Those are all things that we're going to need. So we'll continue to need engagement from you all. So thank you. Now we can go to questions and discussion.
Yes. Yes, we can go to questions, and I'm sure as we continue, people will start to think about things they have experienced that they might want to share with us. So we have a question from someone who has a family member who had a serious illness last year and ended up, he actually says he would have, he participated in the True Cost survey, and that if he were asked now, he would answer it in a very different way, because between that time the True Cost survey went out and now he has had this experience where a family member fell ill, and he says FSHD can make people more vulnerable to other illnesses, for example, respiratory disorders. And over the past 5 months on our behalf, it has cost our insurance company somewhere around $500,000 and us personally $50,000. And it may have also ended a professional career and related future income. And that can happen. And one of the challenges with the True Cost survey is that it's what you call a kind of a cross-sectional survey. So we went out to our community, and thank you everybody who took the time. It was a huge survey, a lot of work we know on your part to do, but it was so important because we want to capture, everybody knows here that FSHD, can vary tremendously in how it impacts you at different stages of life. So in a cross section, you hope to capture that spectrum, that there are few people, on one end, minimally impacted, and at the other end, bearing these huge, $500,000 expenses and so on, and that somehow then you can get an average across this population that represents the cost to the community. But it's hard to do, and the smaller numbers you have, the more uncertainty there is, and how well that reflects. Yeah, go ahead, Josie. Yes.
Yeah, I could just add. So Ray, yeah, this is really important when in this decision, and it is always intended that decision makers are trying to look at the holistic, at least the medical. Not everyone looks at everything, but it's certainly in terms of healthcare use, healthcare utilization is the term that's often used. Those costs, regardless of whether they're from what may seem like a comorbidity, so something that's you've unfortunately developed that you're more vulnerable to because of FSHD, that ought to be captured. And as June says, these decisions are being taken by these decision makers at a population level. That then filters down to individual decisions that you might make with your clinician about the treatments that are right for you. But these decisions that we've been talking about, the kind of health technology assessment, are a population level. And as June says, then you're hoping that everything balances out. There are a lot of challenges of that within rare diseases, and the rarer it gets, the harder it is, because there's so much noise in the system and very small patient numbers. But ultimately, you're hoping that that's what you do. One of the things that's really important in this work is to also be able to describe the limitations of the work, and that leaves the door open to bring in these examples. Sometimes we might supplement the quantitative data, the numbers, the hard numbers, with sort of vignette stories, illustrative examples of what happens to actual patients and their pathway and their experience with FSHD, to demonstrate and bring to life the numbers from the population level with examples of real patient experiences. I hope that helps you sort of understand how that experience is.
That's a great answer. And somewhat related to this, Cindy asks, when looking at this chart that we showed earlier, what stage of the disease does the FSHD column represent, and how do you define that? And that has been one of the things we have wrestled with, because it represents all stages, and it brings us to the question of the disease model or models that we also need. So do you want to talk about that?
Absolutely. This is why this work sort of predates Mercury in a way, because one of the first things we want to do with Project Mercury is be able to define those health states in a way that makes sense. And by that, I mean make sense to yourselves as a patient population or people living and have family members affected by FSHD, but also makes sense to the clinical community makes sense to the payer, the health technology assessment, the policymaker community. So we're looking at what aspects of FSHD would have a really significant impact on your quality of life. What aspects of FSD which have a really significant impact on your clinical outcomes, if you like, and the clinical interventions that you might need, and which aspects of FSHD might have really significant impact on the financial, so on the economics of it all. That might be personal economics, it might be home adaptations, the need for a specialized vehicle, or it might be around the 500K costs that you've referenced in terms of respiratory disease. So at the moment, we're having conversations with clinicians about how we can access some data and bring together a small advisory group who will help steer that work. And we'll be looking at what data is actually out there and what that starts to tell us, and reflecting constantly. So a very iterative approach, talking with people in the community to say, does this reflect? What we will end up with will not be perfect, I will tell you that now, because it never is. But hopefully it will be a big step forward on having no real model that people are feeling comfortable and confident with. And what we will try and do is get the best fit between what the community tell us and what the data is able to do. We will highlight where there are data gaps, and we will be, going out and saying to clinicians, please start collecting this information. It's really important. We'll be hopefully putting those gaps into the registry work that's also happening as part of Project Mercury, and say, please start telling us about this because it's really, really important. Will be some gaps. I can almost guarantee that now, because I've never worked in a rare disease which doesn't end up identifying really important bits of information that we just don't routinely collect until we start doing that work. And then we will hopefully absolutely be able to then revisit the data and say, can we tell which of these health states, which part of the disease progression, if we like, do individual answers come from? And can we give differential cost, differential experiences based on that data? Do we need to ask additional questions or do additional work to be able to do that? So you're right, it's super important for decision makers to be able to see that there's a difference between very early or FSHD that's not having such a full body sort of impact through to the most severely affected patients, and being able to understand the differences in the clinical outcomes, the quality of life, the cost of the condition in those different groups is really fundamental to decision making about, okay, if we give a treatment at this point, we might defer and put off the awful consequences of not having given that treatment. And that's really at the heart of this work program.
Great. Thank you, Josie. Here's a question for Amanda about the burden of illness studies. How were the control groups selected to avoid confounding factors? For example, were they age matched? Were there attempts to control for comorbidities?
Oh, wonderful. Yeah. So this is a great question. And the answer is yes, they were matched by age, they were matched by gender, as well as geographical location, whether the person was in a suburban versus rural area, as that can impact costs. And then I believe they were not matched on comorbidities, but that was a sub-analysis that we did to understand, if you have multiple comorbidities versus all you have is FSHD and otherwise you're healthy, what does that impact have? So yeah, they were very tightly matched to control for as much of that as possible. That's a wonderful question.
This is a question pertaining to Medicare. So Josie, I don't know how far you've gone down into what happens in the US, but it's a question, does Medicare drive coverage and price that private payers accept? So do they, in a sense, set the standard or not?
I would say, and I'm not an expert in the US system, but I have done some work in the US system, that it's very variable between different insurers and different payers, and it is changing quite a lot.
Mm-hmm.
So 10 years ago, 15 years ago, I would have said, no, really not connected at all. Actually, now I think increasingly there probably is a connection. And part of that is about the role of ISA, we've alluded to quite a lot, in terms of having that published look at what does a reasonable price seem under their system. And whilst that's not directly dictating the prices that are being paid by insurers, by Medicaid or Medicare, it's certainly informing those discussions. So whether it's Medicaid setting the pricing, or this sort of external view setting, sort of helping direct the pricing in all groups, there's probably in some areas a bit more shift towards things coming together, but that is an outsider perspective, if you like, of what I see from the other side of the pond, not necessarily how it might feel when you're in the thick of it.
Yeah. I think there's an overall sense that Medicare maybe sets a kind of a standard for if something is covered at all. I mean, that, for example, they issued guidance on reimbursement for physical therapy, for maintenance physical therapy. And yet, we hear about people whose private insurers are not necessarily adhering to that, but then you can go to Medicare and say, well, Medicare does it, why aren't you? So it's a complicated landscape. We're going to figure that out. There was a question, this may also have to do with insurers here, but about prescription coverage for drugs. And there's concern of what happens when you get into your 60s, I guess, if you get into Medicare, and whether you have prescription coverage or not. Do you know anything about that?
I don't.
Yeah, I mean, I think that might be a little, I'm not sure if I quite understand the question, but I think it really depends on, your insurance or your Medicare plan, whether or not you would have that sort of coverage. Yeah, I'm not sure how
I'm
else
not sure.
to answer that. Sorry.
It might have to do with, I think some of the prescription policies can be very expensive.
Mhm.
Of course, there's a lot of debate going on in the government about the cost of prescription drugs. So keep an eye on that, I'd say.
I think that brings back to, when we started with those key success factors, the policy environment is hugely important. And the work that Amanda's been doing on the Hill, the work that other rare disease patient organizations doing, other more common patient organizations are doing to help influence and shape those policy discussions is going to have an impact on you down the line and through the years. This bit of work we've talked about is really FSHD specific and focused on the data. And that's the part that the FSHD Society maybe can't control, but can absolutely really drive. Other things, you'll be part of a much broader, bigger policy discussion, and this sounds as if it is. Every country has a different system, and I'm afraid the US does have a complicated system when you look at it from the outside, and you do tend towards much higher costs, so co-payments, than really anywhere else that I've ever worked with. So I don't want to say something that is reassuring and find that it's totally wrong. So I think I'm going to sort of not get involved in any specifics on any individual plan or payer organization. But it's certainly something that the US working group are likely to sort of start getting into the weeds of a little bit more, I expect, in the next couple of years.
Yeah.
So
Actually, June, I see a similar question here, and I wonder if this is what that first person was getting at. Marion, I found with clinical trials I've aged out of being considered to participate. Will that be the same case when the drugs are on market and being considered for those drugs? So if you're older, than what the clinical trial is currently recruiting for, I think that's a really common question. And
that can. Sorry.
Oh, go ahead, Josie.
No, I was going to say it really depends on a lot of the time on what ends up being in the license. So all clinical trials are done in a controlled population to give the best chance of demonstrating that the product has an impact. And so they're always carefully controlled. Some are quite broad, but they're controlled. There are entry criteria, there are exit criteria, and age is quite often one of those criteria. People don't want to have to deal with too many comorbidities. They don't want to deal with too much noise in the trial data. They want to be able to have as much clarity around the impact of that new treatment. That is slightly different from what the license would be. So what does the FDA end up saying, or the EMA in Europe, for example? What do they end up saying is appropriate for the use of that drug? Now, sometimes those licenses or labels are very much mirroring the trial. So they're mirroring the restrictions that are put in place in that trial. So if they say it is only between the ages of 18 and, I don't know, 45, then it may be that that's the label. It's not always the case. So sometimes a trial that might be done in 18 to 45-year-olds, and I'm making up the numbers, so please don't think I'm referring to a specific trial, could get a label of patients over the age of 18. And the assumption then is that the evidence would hold beyond that. Now, there might be confounding factors. It might be that the treatment would not be recommended if you're on other products, other treatments you might be on because of your age or comorbidities. There might be all sorts of things. So I wouldn't want to guarantee you that wider label would guarantee you access, but that's a really important distinction. So what is it going to be approved for? Because usually, not always, but usually, certainly health technology assessment, they're looking at that label, and often payers are looking at least to start with the patients who most closely match that trial and the label that the FDA have given. And then they might think about broadening that out. So it's really important to understand that it doesn't mean you won't, but it also doesn't mean you absolutely will. It's just sort of keeping an eye on that, I'm afraid. Sorry, I jumped in.
No, that's great. I mean, you explained it perfectly. And the one thing I would add is that, you know, for the upcoming therapies for FSHD, obviously, our understanding of the space and what we're advocating for is that there is no reason to exclude someone from that treatment just because they're older than the trial criteria. And we know that that's how the companies believe and approach it as well. So, you know, we don't have control over what the FDA decision will be, but that is what we are certainly advocating for and presenting evidence for. And then the option, kind of the other factor that comes into play is that even if a drug label is more restrictive than we wanted, there are ways that you can, the doctors can prescribe off-label. And this is actually where some of like our advocacy efforts come into play because, for example, one of the pieces of legislation that is working its way through the committee, one of the subcommittees right now is shoring up, helping to ensure that there is coverage for drugs that are prescribed off-label in rare diseases. So that sort of a bill is great for us to get behind because when needed, if something for FSHD needs to be prescribed off-label, we'll have a better chance at getting coverage for that. So you can start to see how all of these things really intertwine and all play off of each other.
I had another question. We maybe have time for one more from Ricardo, who, first of all, thank you for your work in Project Mercury and your advocacy in the U.S. Congress. And he mentions Project Mercury. Does it still have the objective of building a group of 10,000 well-characterized patients? Yes.
There's a simple answer. Yes, absolutely.
So we've really focused in this webinar on the access work stream, but there is another work stream, another set of aims in Project Mercury that focuses around trial readiness, both within the patient community and having thousands of patients ready for trials and engaged worldwide, and also within kind of the clinical trial infrastructure and clinical community, making sure that there are trial sites that are available to run all of these trials and clinicians that can run all of these trials. So yeah, that is a whole separate stream of Mercury that is absolutely still happening as well.
And actually, here's another interesting question because we have some Europeans on this Zoom. Is it an advantage to be in the public healthcare system once EMA approval has been received?
So it doesn't say what country you're in. So, you know, it is different everywhere. Europe is a big place, and there are, you know, varying numbers, and in the UK, still in Europe, but obviously not in the European Union. So I can't answer that question for you. What I can say is that typically in Europe, for rare disease treatments, the public system will end up either taking on the full cost or the vast majority of the cost of those treatments if they are approved. They will nearly all have a health technology assessment process. Pretty much everywhere in Europe does, and they work slightly differently. The German system is quite different from the Spanish, from the French, etc. But usually, I believe most patients are in some version of the public healthcare system. Now, that's a very general statement because I don't know which country you're from, and it might be a very different system there. The UK, for example, you're going to want to be in a public health system eventually and ultimately because you won't have to pay for those treatments, or you'll be paying, £5 a month for those treatments. Whereas if you're wanting to get something that is accessible, it's approved by the EMA, and you want it right now, quickly, and you're able to afford that, you may well end up going down the private patient route in the first instance, because these processes tend to take time. Mercury, and we're working hard to try and shorten the gap between the EMA approval we hope that we're going to get and the access through those public health systems or health insurers. But there's nearly always a gap, and at the moment that gap, depending on which country you're in, can be weeks to years. So I think you need to understand a little bit more, and that's part of what hopefully, if you're in one of the Mercury countries, we'll be working with you to help you do that, is understand what the system looks like in your country, and then make those decisions appropriate. But those are some of the factors that you might want to consider.
That's a really good point. I mean, many of the European countries have FSHD advocacy groups, and it's important to be involved. This is a time where they need to hear from as many voices as possible, and for you in turn to spread that word to other people, because we can do all this work, but if there's no one there listening, it won't have much of an impact. So with that, Beth, if you'd like to come back, and I will thank Josie and Amanda and turn off my camera.
Yes, wow. Thank you so much, Josie and Amanda. This was a lot of very enlightening information to take in, but it's also really helpful and very important information. So we all have our part to do to ensure access to therapies for FSHD. So when you hear the name Project Mercury, you'll know that there are folks all over the world working really hard to ensure patients everywhere have access to FSHD drug therapies when they are available. So thank you again, Amanda, Josie, very much. Thank you everyone for attending our webinar today. We do not have an FSHD University webinar scheduled for June. Rather, we hope to see you all.
We do, actually.
Oh, I thought we were going to have a biennial FSHD Connect conference instead.
Well, that's the week before.
Okay.
It happens that our third Thursday in June is June 20th, which is World FSHD Day.
World FSHD Day.
But we have,
excellent.
This is exciting. We haven't had a chance to post it yet because we're still working on the language, but Avidity has agreed to share their interim data at our June 20th webinar. So we'll be posting that on our calendar.
Very excited for that. So correction, we do have an FSHD University webinar scheduled on June 20th, but we also hope that everyone can come to our biennial FSHD Connect conference on June 15th and 16th, just prior in Denver, Colorado. But be sure to visit our website. That webinar will be posted soon, I'm hoping. And just visit our website events calendar for all of these upcoming chapter, wellness, educational events. There's so much on the calendar that can help everyone. So thank you again, Amanda, Josie, for joining us today. Thank you all for joining us today. And we'll see you next time. Take care, everybody. Bye-bye.
Bye.